Do bone strengtheners help ease bone pain?
The bone modifying agents like, I have to say, bisphosphonates and denosumab, I don't think that they are directly treat bone pain. I think what I see in my patients, when I treat patients for multiple myeloma and they go into a fast remission, I decrease substantially the burden of the myeloma cells. And by decreasing the burden of the myeloma cells, I also decrease the osteoclast activating factors. So I mentioned already osteoclasts are the bone resorbing cells. So I take the factors away that activate the osteoclast. And with reduced osteoclast activity by less myeloma cells, in addition to the bone modifying agents, patients experience less pain. So it's amazing that patients who go into complete remission have almost no pain need anymore. So I see that in, I would say, 90% of my patients, a drastic reduction of the bone pain. It takes a while. So very often it takes 6 months, but it's amazing how well we can treat pain by just bringing the myeloma into a remission. I'm not sure whether we can really state that the bone modifying agents are modifying the pain directly. I think by reducing the bone destruction, patients experience less pain.
How often should bone strengtheners be administered?
There's so many studies out that there is substantial confusion, even among experts, how often and how long bone modifying agents should be given. Let's talk about Zometa. The recommendations from ASCO are monthly for 2 years. But there's also a study out that giving Zometa every 3 months is as good as giving it monthly. So there's substantial disorientation, to be very polite, to give it. What I do is, first of all, I put all my patients on bisphosphonates when they are diagnosed with multiple myeloma and when they have the need of a systemic treatment against multiple myeloma, period. I usually do that with Zometa. I start a monthly treatment for at least a year. I want to have a saturation of the skeleton with Zometa. And then in the second year, I either stop Zometa already, if patients have no bone disease or no major problem with their bones, or in case I think that there is a need for continuation of Zometa, I spread the interval to every 3 months. So why is that? So first of all, we know that Zometa has a very long half-life time, 8 years. So Zometa binds to the skeleton, and even if you stop Zometa, you still have it in your skeleton, and when osteoclasts do bone resorption, they are inhibited by Zometa. So we know that the drug lasts for a longer time. So that's why we give it for a limited time, and I think it's relatively safe to stop Zometa after a year or absolutely after 2 years when patients are in complete remission. When you do not have any myeloma cells that activate the osteoclast and you have your saturation of the skeleton with Zometa, you can stop it. Why do we stop it? We learned that the longer patients are on Zometa, the higher is the risk for the osteonecrosis of the jaw. Once you have, we call that ONJ, you have to stop the bisphosphonates for good. So what I want to make sure that patients do not develop ONJ, osteonecrosis of the jaw, and in case they have a relapse, that I can restart the bisphosphonates for potential protection of the bones.
There is no clear answer on the dosing of bisphosphonates. Different specialists may have varying opinions. It is best to discuss your unique situation with your myeloma specialist to come up with a treatment protocol that's right for you.